I want to bring to you a little bit of a paradigm shift of what we can think about in terms of navigation. And what we're going to leverage here is, let me go through my disclosures. Some speaking engagements, royalty work for Medtronic, and I am involved with the entity that has helped develop this technology, which I've been involved with for over 5 years now. So there is a bit of an overlap there and conflict. But let's talk about this in very generic terms of what 3D printing is bringing to spine surgery and how that could be applied because of the fact that 3D printing is so unique to each individual patient, in this case, each individual vertebrae, and is very dynamic in the way it can be used, both as a manufacturing tool of our implants and even at the site of use. So where things get printed and how they get delivered and how that affects our efficiencies is the sort of thing I want to talk about. So in terms of navigation, what we're going to talk about here is a single-use, disposable, 3D printed, patient-specific drill guide. And with that, we're going to talk about a backplane of pre-surgical planning that has removed all the heavy lifting. So that 15 minutes that a surgeon was willing to spend, it's pretty hard to pre-surgically plan a complex surgery in 15 minutes with the technologies we have today. Now, with the advancement of robotics and the ability to have machine learning, computers will eventually do a lot of this work for us, even in the operating room. But currently, surgeons are having to do that heavy lifting. And so this is a platform that takes that away from us and allows others to do it for us under our control. So where do we start? We do start with a high-resolution, high-quality data set. So this is CT scanning. A 3 millimeters cut will not be sufficient for this. Why? Because what we are doing is taking that CT data and we are putting it through a very rigorous segmentation process. So this modeling, this computer modeling, is far more specific and accurate than what we may be doing with some of the three-dimensional reconstructed images that we've seen here today, and I'll touch back on that. That gets uploaded and a pre-surgical plan gets developed that is directed by the surgeon. Once that has been approved, then the guides are manufactured and the whole front-end loading of all of this technology of pre-surgical planning, three-dimensional analytics, and the patient specificity of a 3D printed device, all of that technology is uploaded and embedded into a very simple exercise within the surgery itself, which is that 3D printed template or guide. I'm not going to belabor a lot of the literature. I think it's been covered beautifully today. The one highlight I want to point out is that all of the literature, if you really kind of synthesize it, tells us that we as surgeons have to make a very tough choice. When it comes to radiation, either our patient gets it or we get it. And if we're willing to accept a lot of radiation, we can reduce the amount of time it takes us to do the surgery. That's freehand technique. And here you see some of the data where in 10 nav cases versus 10 freehanded cases, 8 times the radiation dose with freehand, but the freehand technique was twice as fast. Or upwards, 2.77 times the radiation dose with CT-based navigation for the patient, and 2.5 times less for the surgeon. So somebody's going to get zapped and it's going to cost us time. So either way, we have to make those decisions. Let's try to mature these technologies and look for solutions that are a win-win on both of those fronts. Another interesting comparison in this Roser study that I think was referenced earlier, I think Dave Polly talked about it. I've kind of looked at it a little bit of a different way. This is basically looking at freehand versus navigation versus robotics. In terms of radiation dose, it's what you would expect. Freehand certainly has the highest radiation exposure intraoperatively, with robotics being next for the reference process, and then image guidance being the least. This is for the surgical team, so you can see why IG falls to the lowest in that situation. And it's the exact reverse when in terms of the amount of time required, image guidance being the most time hungry, robotics, and then freehand being the most efficient. This is an older study. I don't think it's been mentioned yet today, but it's one I really like. Harry Shufflebarger looked at this back in 2006 and really compared us as workers, because that's what we are, as technicians and surgeons, to any other worker out there that has environmental exposures. And in their calculus, the average spine surgeon using fluoro was achieving their maximal OSHA allowed radiation exposure within 10 years of practice. I've been at this over 20 years. I'm sure there's lots of senior surgeons here as well. That's a very sobering analysis there. This kind of data here is something, these numbers have come down considerably, but I left it here only because I think the thought about how we set our machinery, high definition settings versus average settings, and what that means. This is something we need to look at when we drill down into various data points and studies that talk about radiation exposure. Another interesting point that was brought up earlier today about looking at different ways that the body receives radiation and ionizing energies. The idea of a DAP concept, cone beam emitters and helical emitters are going to give you a different kind of exposure, namely where a conical beam is going to repeatedly expose the same area time and again to develop its data set. Helical emitters do not do that. So your helicoil CT scanner down in your main OR department, you need to look at how much radiation it's emitting, yes, but you also need to look at how it's emitting that and exposing your patients. Certainly in the pediatric population, this is important when we put relative value on what the radiation could mean to that individual in terms of harm. So let's do a little bit of a comparison between patient-specific guides and where we are today with IGS and robotics. They're both highly accurate. I'll talk about the guide accuracy in a little bit. 95 to 97%. Guides have tested out at about 99%. I don't think those are going to be significantly statistically different numbers. But we do know there are nuances with that, specifically that the accuracy with image guidance and robotics can degrade depending on movement of the spine or distance from a reference element. However, it's also very helpful in the use of percutaneous surgery. Patient-specific guides are very consistent. It doesn't matter where that vertebrae is in space. You're docking this guide on a bone structure, and it doesn't matter its relationship to an adjacent structure at all. So the ability to move that structure around and still remain accurate is endemic in the way this technology functions. It certainly has an application primarily to open constructs. Intraoperative radiation, most IG systems and robotics still require some form of radiation. I'm going to talk to you about my experience where we don't even bring our C-arm into the room anymore. It's a zero radiation footprint. My surgical team loves that. We have an expression, we say we've shed the lead, and it's nice to be able to go into a surgery and not have any lead on whatsoever. These are both very high-tech platforms, but they leverage the technology in a different way. Certainly, image guidance and robotics is highly technical, but that technical exercise is happening in the operating room, and that requires time and effort, learning curve, and expertise. This technology front-loads all of that high-tech element and has it happen before you ever get in the OR and condenses it down into that guide and emulates it through the pre-surgical plan. So the actual exercise of that high technology is occurring in a very simple and intuitive way in the operating room itself. So from that comes some significant efficiencies and some alteration in dynamics. We don't have to alter our workflow. We are certainly able to use pre-surgical planning and leverage that. The difference I want to point out here is that most of the CT scanning imagery that we are using with robotics and image guidance currently is using it in its raw DICOM form. So we are looking at axial views, we're looking at sagittal and coronal views, and we are in our own mind's eye having to synthesize the three-dimensional element to that. You'll see from this pre-surgical planning platform that through segmentation, we have a very powerful modeling that allows that three-dimensional imagery to be available to you visually in the operating room in a more digestible format, but even more importantly, in the form of an actual bone model that is printed and is part of your available tools in the operating room. Namely, that bone model is autoclavable, it's on the field, and it's something that you can work with throughout the surgery to enhance your understanding of the three-dimensional elements of that surgery. And then the cost structure, which I think has been discussed. So when I first looked at this image on the front cover of Spinal News, there's something that kind of didn't sit right with me when I first looked at it. And it took me a while to kind of condense what that is. And that's simply that here you have two surgeons and an assistant, and none of them are actually paying attention to the patient. They're all out there looking at monitors, and they're distracted and removed. The analogy of GPS and how IGS and robotics is analogous to GPS, I think is a very good one. But I think that analogy has to be brought to its logical conclusion, which is namely that IGS and robotics gives you GPS, but it also forces you to put on dark sunglasses where you're not really able to see around you. You're not able to use the simple dead reckoning that each one of us uses every day. And so in my mind, the ultimate navigation technology is invisible to the end user. And more importantly, keeps the end user focused on the subject, focused on the patient, not on something happening out here. Accuracy, I mentioned about 99%. This is all through cadaveric testing and compares, I think, very favorably. This is the Gertzbein-Robbins classification that was used earlier. Suffice it to say, I think all of these technologies are superior to freehand. So where did I start with this? I want to talk to you a little bit about my personal adventure with this. This was a concept that was hatched really back in about 2010 as 3D printing and biocompatible resins became more readily available. We did some early pilot work, basically 6 cases that we did in 2012, short, simple segment surgeries, and used it. This is an image from one of my cases back in 2012. Used it really just as a way to supplement a standard freehand technique, dead reckoning. You could see I'm not putting any screws through that guide. I'm simply drilling or cannulating a pedicle. However, I think more valuable is looking at where we've come to now years later. And in a pre-submission, I'm going to give you some pre-submission data here, pre-publication data, that over the past 24 months, this is single surgeon, single center, about 45 long segment cases. The preponderance are adult deformity cases, a small amount of AIS cases, and 30% of those are revisions. It's about 800 plus screws. These cases all had CT scans preoperatively for the purpose of the pre-surgical planning, but more importantly, post-operative CT scan for other reasons at the 6-month mark, where we could then compare accuracies, just as was discussed earlier with robotics. And this to me is a true measure of accuracy, where we're taking a pre-surgical declared trajectory for a screw, not where we think we might want it to go, but where we actually planned it to go to a sub-millimeter level of accuracy, and then comparing that to a post-operative CT to really be able to give a good comparison between the two. So that individual had that particular surgery performed. It was a revision. He was a gentleman who had had an SCI many years earlier and had developed a Charcot spine. You could see how our modeling was really able to address issues of bone removal, hardware placement, prior fusion, and he's now back to being a really Olympic grade sled, hockey sled athlete. Really interesting guy. So how did we analyze our particular data? Qualitatively speaking, we really just looked at the Gertzbein-Robbins classifications. We did not have any grade 2s or grade 3s, so that means that all of our screws were in the no breach or the 0 to 2 millimeter breach category. More importantly, we then went ahead and compared the pre-planned trajectory, which you see in green and blue, to the actual achieved trajectory that you see in red. So this is sort of a visual view of what was accomplished. What were the actual numbers? Deviation in the transverse angle was 1.53 degrees. In the sagittal plane, about 2.2 degrees, and entry point deviation of about 1.5 millimeters. So again, I think an accuracy level that falls very close to what can be accomplished with robotics. And I think this is kind of the standard that we're going to expect from our navigation technologies moving forward. My personal experience in terms of how long does it take to implant a screw, this is a learning curve of, I think that's about the first 20 cases that you see there. 2 things to note. Obviously, as we had to go through our learning curve, we get faster. This curve is now down at about 1.5, so 1.5 minutes per screw. But you see some variability, and that's because these are long segment deformity cases, revision cases. These are tougher surgeries that just fall into my practice, and thus there is certainly still some variability even with this navigation tool. Use of fluoroscopy, we used it early on for verification and validation of what we were seeing for accuracy in cannulating the pedicles, but from about that 6th case on, we essentially are doing this part with 0 fluoroscopy. And I'll talk a little bit about how we can accomplish that. So as I said, this starts with really robust pre-surgical planning. And the idea here is that you have a number of technicians who, on your direction, will do this plan for you ahead of time. They want to know things like, how do you like your screws placed? Do you hub your screws or not? They want to call out to you controlled breaches, as you see here, and want to image it for you in a way that gives you the information you need to decide if that screw position is adequate for you. And this is reduced to a digital plan that's available in the operating room itself. The guides are then produced and brought in, as you see here, and they're staged in a way that's going to help enhance your intraoperative efficiencies. I mentioned the bone model. This was something that early on I didn't really appreciate what its value can be. And bone modeling is available in a lot of forms. I would encourage you to consider it regardless of if you use navigation or not. But the ability to identify really complex anatomy and to use it as a patient education tool in your office before you ever go to the OR, I think is very, very helpful. The way we get away from fluoroscopy altogether in the OR is that we use this model to identify our levels. So when we do initial exposure of the spine, we are able to then look at nuances on that bone model. This transverse process is lumpy. This one's very sharp and pointed. This one's bent this way or that way. And do a correlation visually between the anatomy that we see and that model. And from that, we're able to actually determine our levels very, very accurately. This is especially helpful in the idiopathic scoliosis patients in the thoracic spine, where there aren't a lot of good landmarks, and counting ribs and counting levels can be difficult and require a lot of fluoro shots. So the bone modeling is something that I think is very, very helpful. The pedicle trajectories are built into these bone models, so even if you have no interest in using a navigational guide, the bone model allows you to look at where your entry point should be, put, say, a K-wire or other little indicator in that hole, and allows you to really see what your vectors and trajectories need to be. So in your mind's eye, you can enhance free-hand technique without having to have other complex devices in the operating room itself. And then, of course, if you're doing more advanced work on the bone structure or have more advanced conditions, like this big widely decompressive laminectomy, you can start looking at foraminal volumes. You can look at how, in this case, a multiple compound guide fits on that bony anatomy, and really figure out how much bone do I need to remove to open up this foramen. That one's fine, this one is not. Is my cob gonna fall into that big laminectomy defect or not? You can actually take that instrument and apply it to this bone model, and it will really change how quickly you even expose your spine. If you know that your cob elevator has no chance of going into that laminectomy defect, you're probably gonna move through that exposure just that much quicker. So there's a lot of dry run of the surgery that occurs before you get into the operating room with this kind of technology, and it makes you more efficient intraoperatively. You're not having to figure that out real time. So let's launch this quick video here. And unfortunately, it doesn't have the time counter down on here, but you'll see this exercise of placing 2 pedicle screws taking 3 minutes. So basically 1.5, yeah, there you go, maybe it'll come up, 1.5 minutes per side. So what's occurring here is I'm the surgeon on the right, I'm holding the guide in place. I'm the one who fitted it, I'm the one who has to be sure it's in the right place. My assistant affixed it to the bone structure with 2 fixation pins. We've kind of had a mixed experience. Some surgeons really prefer to transfix the guide so it can no longer move. Others simply hold it in place through the whole process. Apply a drill sleeve, and then drill to a predetermined depth based on your pre-surgical plan. And one of the benefits here is that you can work across the field. So at least in my hands, I would typically cannulate and instrument one side of the spine and then go to the contralateral side and do the other side. Here, because it's a mechanically constrained drill guide, I do feel comfortable leaning over the patient and actually drilling the contralateral side from just the one side of the table. So these are some of the efficiencies that just make everything go a little bit faster. We also don't want to change how the surgeon does their normal technique, and so being able to use a pedicle probe, we heard some data this morning that says it's not very accurate or instructive, but I think most of us still do it. And so certainly this doesn't prevent you from palpating that initial pilot hole that you've made. Next step then, if you so choose, is to go ahead and tap the hole up to either line to line or under tap as you see fit. And these are all obviously depth controlled or depth marked as well. And notice we're doing all of this under power, so that's certainly something that a surgeon has to be comfortable with. You can do it using a manual awl or hand-driven instruments. It just works a lot better under power, I believe, than it does manually. And then this guide comes off, and you can again check your holes as you see occurring here. If at that point you want to drop your screws, that's fine, you can do that. If instead you just want to put a marker in place or modify the bone with a rongeur, Ponti osteotomies, whatever your plan is, this is the time at which you can do that. And here you see me going after the transverse process with a bit of a rongeur there to modify things. Then you'll see that we place the actual screws themselves. And again, in my hand, probably the past 5 years, I do almost all of that, including screw placement, occurs under power. So how do we enhance the efficiencies, and how can our team really stay ahead of us? Well, it's really in organizing the process ahead of time. So what you see is the guides in place in a sequence, but you notice that we've already matched them up with their corresponding screws that have been called out as based on the pre-surgical plan. So all of this is done while the patient's being positioned and is available such that your technician not only has the images up on the screen that the entire team can review to know what level we're at. You may have noticed up there, it also calls out the specificity of the screw in length and diameter. And if we can launch this about 1/3 in, what I want you to notice from this is 2 things. Number one, there's no C-arm in here. We don't have the C-arm in at all. We've got our plan, that's the pre-surgical plan that's been agreed upon, already on the viewer. And while I'm fitting this guide in place, my scrub tech here is already beginning to load the screws. So we're not waiting to palpate the hole and make some measurements and gee, I think this is a 6.5/45. He's already loading that screw because he knows what level we're at and he knows what we've called out. So if you think about that 30 seconds that you wait for that inexperienced scrub tech to go in the back and hunt around for that screw that you asked for and multiply that in a long segment case, you can imagine it's efficient. This is also something that can be brought into the arena of surgery centers in a packaged and disposable, cost-effective process. So really quickly, a couple of cases here of mine, 63-degree, 16-year-old scoliosis, pre-surgical plan agreed upon, implantation time, so that's from when the first guide goes on to when the last screw goes in of 32 minutes, no fluoroscopy required. Here's a case of mine that I'd done 20 years prior, kind of a CD hook rod hybrid construct, comes back 20 years later with the typical adjacent segment issues here. First I thought, simple case, no problem, but after we CT'd it, we realized we had some very small pedicles. I had placed my L4 screw on the left side in the canal. Whoops, that was 20 years prior. And also I'd done a pretty robust iliac crest harvest on one side, making the iliac fixation more than a bit of a challenge. So the beauty of this in the pre-surgical plan was not only to be able to decipher vertebrae within that big fusion mass, but also with a mechanically constrained drill guide to be able to reorient the L4 pedicle screw very easily and pre-plan exactly where that screw was going to go. And even look at the sequence of how I was going to do this surgery. Here's an overlay of the prior hardware to the new hardware I was going to put in. So I could answer the question, do I need to take the hardware out before? Or can I actually just go ahead and start putting in screws and it will avoid the hardware? And if I don't like the answer to that, I can relocate the orientation of my screws in such a way that I avoid the hardware. So this allows the surgeon to remain in complete control in the pre-surgical planning process of how they want to execute through their surgery. Another interesting case, 52-year-old who had had a tumor resected as a child. Basically everything in the concavity here had been removed from L3 to the sacrum. And as you can see now, as a 50-year-old adult, she's got this pelvic obliquity, a dislocated hip, and some very, very abnormal anatomy. Her symptom was pretty basic. It was just pain on standing, all goes away when she lays down. What I want to point out here is when you get these kinds of cases, how helpful is this sort of CT data? When you look at this and you look at this, in your mind, you have to somehow put this together into a three-dimensional structure. That's very hard to do. This image doesn't help you very much. So the ability instead to use a segmented three-dimensional imagery to target your iliac bolts, to figure out where a bone has been removed. Are you going to put a screw here or not? If so, how much is it going to be revealed to the soft tissue, and are you okay with that? These are the sorts of elements that can be very, very helpful in figuring out where do I have enough real estate to even put a pedicle screw in this case? How much can it protrude anteriorly, and what structure is there? And then I can look at it as a total construct. And this is the result that you see in this patient, and she's been very happy with that. One last one I want to show you, and then let's get off to lunch. Would be a case like this. This is a Parkinson's patient, had a prior interspinous process surgery and decompression, sagittally imbalanced. And a construct like this, a T4 to ilium construct, about 56 minutes without the need for fluoroscopy. This is a 47-year-old with a non-union that had cortical screw trajectories placed at 2 levels. Here you can see that the screws are fractured. Now, any of you who use cortical trajectories know that that's going to be a problem for us because that's right in the way of where we want to put our new screws. So the pre-surgical analytics were very, very helpful in this situation. Here, I told my technician, do what you normally would do. Put the screw where we normally put it, and tell me if it's going to interfere with that broken screw fragment on the cortical screw. Okay, problem there. So let's reorient it and put it in a different location. And you can see we were able then to dry run this whole surgery without having to get in the operating room and be doing this in real time. And there is the ultimate result. Similar with anterior construct hardware or compressed vertebrae, finding your optimal location. So my conclusory message here is really very simple. Navigation is going to become, and is really already, a menu of options. And I don't think we are going to see one form of technology that solves all problems. And so the idea then of maybe looking at navigation, both what we do in the operating room with our technologies available, but also what we do before we ever get to the operating room, and enhancing what we do with pre-surgical planning. And in this case, bring that technology into the operating room using patient-specific technologies like 3D printing, I think is an alternative that we may consider valuable in the future. Thank you.